Today, we're doing a deep dive into the German S2K guidelines for herpes zoster. We're going to walk through the exact clinical protocols, the diagnostic criteria, and the treatment recommendations for managing shingles, getting right into the details.
All right, so here's how we're going to tackle this. We've got 4 key sections. We'll kick things off with a quick look at the basics, just for context. Then we'll get into the real nitty-gritty of the diagnostic playbook. After that, we'll unpack the entire antiviral protocol, and finally, we'll cover the specific guidelines for managing that awful zoster-associated pain.
Okay, first things first, let's just quickly set the stage. Before we jump into diagnosis and treatment, what are we actually dealing with on a biological level when a patient presents with shingles? So the key thing to remember here is that shingles isn't a new infection. Not at all. It's actually the varicella zoster virus, the exact same one that causes chickenpox, waking up. After you have chickenpox, the virus doesn't leave your body. It just goes dormant, hiding out in your nerve cells. And that's clinically huge, right? It means pretty much anyone who's had chickenpox is technically at risk. So what gives this sleeping virus the green light to reactivate? Well, it's really all about opportunity. It happens when the body's immune system, specifically its VZZ-specific cellular immunity, gets weaker. The number one trigger is just the natural aging process, what we call immune senescence. But really, any condition or therapy that messes with cellular immunity, we're talking things like malignant lymphoma, HIV, or immunosuppressive drugs, can absolutely open the door for reactivation. Okay, so we've got the basics down. Now let's move on to the really crucial part, the diagnosis. How do these guidelines tell us to definitively identify herpes zoster in the clinic? You know, the classic zoster rash follows this really predictable playbook. It starts out with these red macules and papules, always in a single dermatome on one side of the body. Then, over the next day or so, they bubble up into these grouped vesicles. Those then turn into pustules, and finally, after about 5 to 7 days, everything starts to crust over. This very distinct timeline is one of your biggest diagnostic clues.
So you see that classic rash. But is a clinical diagnosis always enough? According to the guidelines, not always. So the big question is, when is sending a sample to the lab not just a good idea, but a strong recommendation?
So, look, for a really straightforward case on the torso, you probably don't need a lab test. But the guidelines are super clear that you should get one if you see any of these red flags. An atypical presentation, lesions that cross the midline or hit multiple dermatomes, or any case that's not on the torso, like on the head. You also want to confirm it if the patient says they've had zoster before or if they've been vaccinated. You just need to rule out other things, and the gold standard here is a VZV PCR test from a good swab of a fresh lesion. Now, the guidelines call out 2 specific high-risk scenarios that you really have to be on the lookout for: herpes zoster ophthalmicus and oticus. For ophthalmicus, you're talking about the trigeminal nerve. You have to check for Hutchinson's sign. That's lesions on the tip of the nose. If you see that, it's a huge red flag for serious eye complications like keratitis or even vision loss. Then there's oticus, which involves cranial nerves 7 and 8. Think severe ear pain and facial palsy. That's Ramsay Hunt syndrome. For both of these, the guidelines are emphatic. Get an immediate referral to the right specialist. Ophthalmologist for the eye, ENT and neurology for the ear. No waiting. This is so important. Figuring out a patient's risk right at the start is a total game changer, and the guidelines give us this clear framework. So anyone over 50 is at higher risk for postherpetic neuralgia, or PHN. If the zoster is on the head or neck, the risk isn't just PHN, but also neurological problems and even stroke. Having severe pain right at the beginning, that's another strong predictor of PHN. Same goes for a really severe rash. And of course, anyone who is immunosuppressed is at risk for everything: recurrence, dissemination, and even antiviral resistance. All right, so once you've nailed the diagnosis and you know the risks, what's next? Treatment, of course. Let's dig into the specific antiviral agents the guidelines recommend. Okay, here's the nitty-gritty. The guidelines detail 4 oral options and IV acyclovir. Let's walk through them. Valacyclovir is 1,000 milligrams 3 times a day. Standard acyclovir is 800 milligrams, but it's 5 times a day, which, can be a real challenge for patient adherence. Famciclovir is 250 milligrams 3 times a day. And then you have Brivudine, which is the easiest oral regimen at 125 milligrams just once a day. For the really serious cases, you're looking at IV acyclovir, dosed at 8 to 10 milligrams per kilogram, 3 times daily for a week, or even up to 10 days. So for whom is this kind of therapy an absolute must? Well, the guidelines are pretty forceful here. There's a strong recommendation for all patients 50 and older, and anyone with zoster of the head and neck. It's also required for cases with moderate to severe pain or complicated lesions, think hemorrhagic or necrotic.
You also treat multi-segmental involvement and critically all immunosuppressed patients and those with other skin diseases like atopic dermatitis. For these folks, you have to start treatment as soon as you can, ideally within that 72-hour window.
And then there are the cases where oral meds just aren't going to cut it. The guidelines are really specific about when you have to escalate to IV therapy. IV acyclovir is recommended for any herpes zoster of the head and neck, especially in older patients. It's also the go-to for any severe or complicated lesions. That's your multisegmental, hemorrhagic, or generalized zoster. Every single immunosuppressed patient with zoster should be considered for IV. And absolutely anyone showing signs of visceral or CNS involvement needs IV, no question. This is a critical step to prevent really devastating outcomes.
Now, tackling the virus is one massive part of the battle. But the other, and honestly, sometimes the tougher part, is managing the pain, which can be just awful. So let's break down the guidelines' very structured, step-by-step approach to pain management.
To manage this pain effectively, you have to realize you're fighting two different kinds of pain at the same time. First, you've got the nociceptive pain. Think of this as the direct wound pain from the inflamed rash itself. But at the same time, you've got neuropathic pain, which is caused by direct inflammation and damage to the sensory nerves. And that's the one that causes that classic burning, stabbing feeling and can stick around as postherpetic neuralgia. And because you have these two pain types, the treatment is layered. Step 1 is your foundation. Manage that nociceptive pain using the standard WHO pain ladder. So NSAIDs, and if you need them, opioids. Step 2 is to bring in a weapon specifically for the nerve pain. And that means adding an anti-epileptic agent like gabapentin or pregabalin. Then, if you're 2 to 4 weeks in and the pain still isn't under control, you move to step 3. Add a tricyclic antidepressant like amitriptyline.
Now, what about when the rash is totally healed, but that localized nerve pain is still hanging around? For this situation, the guidelines point to topical treatments. The clear first-line choice is the capsaicin 8% patch. If that doesn't work or the patient can't tolerate it, your second-line option is the lidocaine 5% patch.
So there you have it. The German S2K guidelines give us this incredibly detailed, evidence-based playbook for managing herpes zoster. But having the playbook is one thing. The real challenge is always implementation. And it leaves us with a big question. With our aging population, how can we make sure our clinical systems are actually ready to apply these complex protocols to protect our highest-risk patients from the really debilitating complications of this disease?